Thank you for watching our video on Seeg. The purpose of this video is to provide practical information for nursing staff at Abbott Northwestern Hospital who are taking care of patients with Seeg electrodes. I'd like to start with going over just the purpose of Seeg monitoring. So as you can see from this slide, there's several electrodes that are placed in the brain, and they're small electrodes. They're placed through small burr holes. The usual number of electrodes is somewhere between about 12 and 16 electrodes, and they're placed deep in the brain. And the purpose of these electrodes is to localize very precisely where in the brain the seizures are coming from. So as you can see, those electrodes will go to areas of the brain that can be difficult to localize with those scalp electrodes. So people are used to those EEGs with just the electrodes on the surface of the brain. Imagine how much better you can localize things with these Seeg electrodes. And so it's mainly for patients who we have a good idea where the seizures are coming from. Seizures may be coming from the temporal lobe or from the frontal lobe, but we want to be more precise on localizing the seizure focus. What I'd like to talk about now is more of an overview of the hospital stay. So even before the patient comes into the hospital, I want to review what happens before they come in, what happens during the hospital stay, first day with those electrodes placed, all the way to the end where the electrodes are removed. So before the admission, the patient undergoes a pre-surgical evaluation. So this is a very extensive evaluation where the patient undergoes EEG monitoring at the hospital. We localize where the seizures are coming from. They've had MRI of the brain, PET scans. They've had neuropsychology testing. We as a group have gotten together to discuss the case. So we have a surgery conference, and we've come to the conclusion that we have a good hypothesis where the seizures are coming from, but we want to localize those seizures more precisely. And so those patients are then decided, okay, that's going to be an Seeg case, and then we put the patient on the schedule for the surgery. Before they come in for the surgery, there's something called trajectory planning. So each of those electrodes, so look at this, all those electrodes, 12 to 16 electrodes, each one, you want to figure out exactly what their path is. Where does it enter in the skull and in the brain, and what's the target? And so each of those you have to plan very carefully, because you want to go exactly where you think the seizures are coming from, but also you want that path to be safe. So they do trajectory planning, patient preparation. A lot of work is done to prepare the patient. We want to make sure that they know what the goals of the admission are. We want to educate them on what Seeg is all about. We want to go over the risks, the benefits. We also spend a lot of time on the safety rules. Patients, if they understand what the rules are, the patients are going to be very happy. If they come in and they don't know exactly what they're facing in terms of the safety rules on the unit, then there can be a lot of frustration. So we spend a lot of time talking to them about how nursing staff will be very close to them as they get out of bed and get into a chair, as they use the bathroom. All those things are very clear before the patient comes in. So during the admission, so day one, the Seeg electrodes are placed. Usually it's a Monday, and it's a long procedure. You have all these electrodes. Each one is like its own little surgery to put those electrodes in. And so it takes time. It's just one electrode after another, very carefully placed. The trajectory is checked and rechecked. And so for each electrode, it just takes time. So the procedure itself, usually patients are admitted early in the morning on a Monday, and they don't really come out of the OR until about noon, maybe a little bit later. And so when they do come out of the OR, they are then transferred to H6000. The patients who get transferred to the ICU are patients who may be very complicated very complicated case, or perhaps there's been a complication, and those patients may go to H6200 overnight. But the usual plan is that patient goes to H6000. Mainly for that is we want to record seizures as soon as possible, and also patients tend to tolerate these electrodes very well. So while they're in the hospital, they're on H6000, and they're usually there for about 6 to 9 days, trying to accomplish our goals. Goals are mainly recording those seizures. So we lower the seizure medications, we do sleep deprivation. Nursing staff is doing their usual excellent job of keeping the patient safe, and also testing the patient when they're having their seizures. And another thing that happens is we often will do cortical stimulation, where we actually will stimulate the brain with electricity and try to trigger their typical seizure. We also do brain cortical mapping for eloquent cortex. So we stimulate the brain with those electrodes, and we can figure out where in the brain language function is, or motor function, or sensory function. So that's what occurs over the 6 to 9 days while in the hospital. And then once all the information is gathered, we've gotten our seizures, we've figured out our plan, then the patient is scheduled to go to the OR, have those electrodes all removed, and the patient then would go home. It's actually kind of interesting. Only about 1 or 2 days. Once those electrodes are removed, patient usually goes home relatively quickly, because again, this tends to be a relatively well-tolerated procedure. I do remember with patients undergoing grids and strips, there was just with a craniotomy, and it was just a bigger procedure. So SEG is just a nicer procedure in terms of patients' tolerability. So after discharge, patient is then sent home for recovery, and they don't have their definitive surgery right away. Remember, the goal of the SEG is to localize where in the brain the seizures are coming from and offer them a resective surgery. For example, temporal lobectomy, or RNS, or other surgery. We don't do that right away. We usually let them recover for a few weeks. I will say that SEG has completely revolutionized the epilepsy surgery. Is just incredible. Almost everybody gets offered a surgery, which is pretty exciting. The days of being able to, or having to tell patients, I'm sorry, we can't localize your seizures. There's nothing we can do for you from a surgical standpoint. And the fact that SEG allows us to offer patients so many surgical options is just a very exciting time for us here. Some of the complications that can occur with SEG is something that nursing staff has to, of course, watch out for. Things like an infection, stroke, hemorrhage, status epilepticus. These are all possible complications in someone who's had all these electrodes placed. So the nursing staff just needs to do what you do. You're very well trained for taking care of complicated neurologic patients and looking for neurologic change that's significant. And so that's what you'll have to be just on the lookout for. We get a lot of questions about electrical safety. So devices are just a very big question. People want to use their smartphones, their iPads, etc. And patients definitely can use them. What you do is you'll plug the device in to charge it up at a kind of separate part of the room, and then when the patient is in their bed, they can use their device just as long as it's unplugged. Then it won't interfere with the SEEG data. Another question we get is about code. Nursing staff very wisely wants a plan. Somebody's having a code blue, they need to have a defibrillation or whatever procedure. Do you have to disconnect the patient? And the answer is no. What you can do is just go about the code without worrying about the SEEG electrodes. Just take care of the patient in the usual way to keep them safe. It's a great question, because not something you want to be checking on. If somebody is having an emergency, you just want to go into action. Patient safety is just critical. Patients with SEEG electrodes, they have all those electrodes in place, and what happens is you have the electrodes in, and then each electrode has its own cord going to the EEG machine. So the patient, if a patient falls with all those electrodes in, it could tug on those SEEG electrodes, and that's obviously a huge safety thing. So keeping the patient safe from falls and injury is critically important. So the rules include 4 bed rails up, pads on, 2-person transfers. Patient is able to walk in their room. There's a tab alarm, and when they're up in a chair, they're on a tab alarm, and they have the waist belt on. Again, all these are to keep the patient safe. And of course, lots of very strict monitoring when they go into the bathroom. So one staff is in the bathroom with the patient at all times. No showering. The way patients can clean up is just in the sink with kind of bird bath kind of things. So that's kind of how the patients can kind of keep cleaned up. Finally, I just want to say who to contact. So you have 2 groups involved with the patients. You have the Minnesota Epilepsy Group, and you have Metropolitan Neurosurgery. So if somebody's having a problem with the seizure piece, or there's a question about anti-seizure medications, you'll call the Minnesota Epilepsy Group. And if there's a change in neurologic status or other neurosurgical issues, you'll call Metropolitan Neurosurgery. Thank you so much for watching this video. If you have questions, just let us know. Thanks.